Hi, everybody. We'll get started in a moment. We're just waiting for one of the speakers, and I can't see her.
I'm here. Hello.
Ah, Anne, there you are. Sorry.
Sorry, I had a clinic that ran over, and I'm trying to log in to Zoom on my work computer where my presentation is. I'm speaking to you on my phone at the moment.
Okay, thank you very much. Anyway, I think we should start because we're 4 minutes in. So welcome, everybody. We've got 40 people on this call, which is great. Particularly with the nice weather, perhaps people have decided to get a shot of vitamin D. So my name's Jack Czauderna. I'm your host for this meeting on long COVID. And I'm a retired family doctor. I worked in Darnall in Sheffield as a GP for 30 years. And I also worked for over 10 years in the regional South Yorkshire and North Derbyshire chronic fatigue service as a GP with a special interest. So we've got 4 speakers this afternoon. Anne Tunbridge is a consultant in infectious diseases. She's going to give us the medical view. Maggie Quinn, who works in the hub, is going to tell us about available help and services. And then my colleague from Darnall Wellbeing, Waqas, Hameed, who's doing some work in a virtual clinic for long COVID for underserved communities, is going to speak about that. And he was going to bring David Littlewood as a sufferer from long COVID, but unfortunately David can't join us. And then Tom Heller, who is a colleague in SCCT, is going to tell his story. And then after that, we're going to go into breakout rooms because with the number of people that we have, I think it's much better that we can get into small groups to have some discussion and ask questions. And I'm hoping there are people in the audience from the hub and people who know something about long COVID who can help us with in the breakout rooms. I'm just going to introduce this session, and then we'll see if we can get Anne to speak about the medical stuff, and if not, then perhaps Maggie, you could speak first.
Yes, I'm hoping Alex has got my slides now. Alex, is that all right?
Yeah, I'm just loading them up now.
Fabulous, thank you.
Okay. So I just, by way of introduction, there's an epidemiologist called George Davies Smith who's in Bristol, which is my old medical school, who wrote a paper about known unknowns in the British Medical Journal in October. And he says, the more certain someone is about COVID-19, the less you should trust them. And this is the uncertainty associated with COVID is perhaps most striking around the issue of long COVID. We really don't know much about this condition, or even what to call it, really. So the language is confusing. Anthony Fauci, who you may remember is the US chief medical advisor and survived his time under the Trump administration, has just recently come up with the term PASC, P-A-S-C, which stands for post-acute sequelae of COVID. Now there's a mouthful. And I'm just using that to demonstrate the way that particularly doctors try to define conditions, not always very successfully. And I've certainly had email exchanges with doctors who have couldn't really understand why this isn't called chronic COVID or other terms. And I think this is important because we do know so little about this condition. And long COVID is a term that's really been coined by and used by lay people and sufferers. And I think it's important that at the moment, until we know more, it should stay. We should use that term, vague as it is, until we know more. We shouldn't be taken over too much by the medics. And the reason I'm saying this is that when I worked in the chronic fatigue service, a significant proportion of doctors, GPs, other medical staff just did not believe that such a condition existed. And so patients were just often not believed, and not believing people who have symptoms is one of the key things that we've got to get across. So that if people have symptoms, they go to see their GPs or their medical people, then they need to be taken seriously with this. There's a quote that I used to use from a paper by Hadler in 1996, which says, if you have to prove you are ill, then you can't get well. And I think that's just something we should think about. So I'm going to, if possible, move to Anne to tell us about the medical view of long COVID.
Well, just very briefly, the reason I'm in a clinic room to get some privacy, but unfortunately that's why my computer's not connected. So I'm going to ask Alex to load my slides up, but I may be able to connect through to you if I go back into my own office. So bear with me. While Alex is just sharing her screen, hopefully with my slides on, I may have an even easier answer. Sorry. I'm going to try and be as multitasking as I can. I'll talk through my slides initially, but if I can get beyond the like the CMO doing next slide, please, and be able to work it myself, that would be my ideal.
Alex will help, though. Alex will help, yes. I'm sure.
So Alex, if you could put my next slide up, it may well be that we just have to do it this way. So we're 1 year on now from the first lockdown, and what I want to go through is what we know now compared to when Boris stood and told us that we all had to stay in our own homes last year. Next slide, please. So I'm going to talk to you about what we now know about acute COVID. Also what we know about recovering from COVID, using some data from both global, so around the world, but also local data from here in Sheffield. And what treatment options we have. So the next slide, please. So one of the problems this time last year, people were starting to get sick with COVID, and it was literally a disease that we as doctors had not encountered before. But we sort of collectively in healthcare systems around the world were very rapidly gathering and sharing data. Yes, absolutely fine for people to have this slide shared if that would be easier for you. So these two graphs show you the proportion of people so experiencing COVID with their symptoms on the left, and the purple is the symptoms were present, yellow is symptoms weren't present, and pink is symptoms they didn't know when they were doing this piece of research. So what you can see is top left is the symptoms that we know now are associated with acute COVID. But as you can see, there's actually quite a long list from top to bottom. So cough, fever, fatigue, aching joints, aching muscles, that's all very common, but there's also quite a lot of other things sort of further down the list. And then the comorbidity, so this is what other illnesses to people who present with COVID to hospital, what do they have? And this is data from 20,000 UK patients from the first wave. So this is data that was presented in May last year. So just to show you how from a disease that we'd not met really at the beginning of March to the end of May, presenting data on 20,000 people. And that's the sort of collaboration that's been happening. So next slide, please. So the other thing that we've learned is what works and what doesn't work for acute COVID. So I know these are very scientific graphs, but I'm going to talk you through. So dexamethasone, this is the steroid, the cheap and cheerful steroid. As soon as we started admitting patients, we started asking the question of what's going to work, what's going to get people better. So on the left-hand graph, that's the number of people dying from COVID. And on the bottom line is time after being recruited to the recovery research project. And what you can show is, so the red line is people who received dexamethasone and the black line is people who didn't. And the lower the red line is from the line that's black, the more the benefit. And what you can see, there's a little bit of benefit looking at all patients who presented with COVID to hospital. The top right-hand graph is where people who admitted to ITU, and that's where we saw a definite benefit in that less people who got dexamethasone and went up on ITU died of COVID when they'd had dexamethasone as opposed to not. What you can also see, bottom right, is if you just looked at people with relatively mild disease, so who didn't need oxygen support at all during their admission, actually they did worse. You can see the red line is above the black. And so this is the sort of data we're getting and getting people through COVID. And we started, as soon as these results were analysed and submitted, we started using steroids in anybody who requires oxygen after they've been admitted to hospital. Okay, next slide. These are the treatments that don't work so well. So blue line is control and red line is the intervention. Top left is remdesivir. It's a antiviral drug, and you can see that the lines pretty much marry each other, which means it made no difference whatsoever. Hydroxychloroquine, which is President Trump's, the ex-President Trump's favorite drug. Actually, you can see the red line is above the blue and actually caused harm, as did interferon. We do not use those drugs. Lopinavir, there was a very slight signal towards benefit, but when they looked at the side effect profile, etc., they felt on balance that was not helpful. So of all of these drugs, the one that we're consistently using is dexamethasone. Okay, next slide, please. This graph is your prevention. So this is what we know works. So this is the COVID vaccine. And you can see, so this is the data from the Oxford vaccine trial. So the blue line is people who had the control vaccine. So when people entered into the Oxford vaccine trial, half of them got given the meningitis vaccine and half of them got given the new COVID vaccine. And you can see the orange line is those who got the COVID vaccine, and you can see there's a massive difference in the number of people who actually got significant COVID disease after having had the vaccine. The graph on the right is after one dose and the graph on the left is after two. Next slide, please. So this is local data. And this, I promise you I'm going to talk about long COVID, but I think this is really quite important. I swear I wish I had my pointer. So the little low graph on the left, the two shades of red that you can see, this is actual numbers of patients presenting with COVID, testing positive for COVID. The light red is those people who tested positive in hospital, and that includes healthcare workers. So people being done at what's called Pillar 1 labs, which is the hospital lab. The dark red is people who are testing positive in the community. And right at the bottom right, you can see there's a little light green, and that's people having their lateral flow test. So that's kids in school and their parents, just happening in the last few weeks. This is since March last year, right up to the 20th of March this year. What's really striking is there is no dark blue sort of spike on that left-hand side of the graph, dark red. And the reason for that is that we were not doing community testing. Now, we know that about 20% of people who are diagnosed with COVID will end up in hospital at any one time, roughly 1 in 5. If you look at the light red on the right-hand side, you can see there were significant numbers of COVID in the community. The reason for the big peak in September, October is the students who were all fit and healthy, 18 to 25-year-olds, and actually hardly any of them came into hospital. But you can see it marks up when the lockdowns began and ended. and the impact that lockdown has on a graph. Where this is relevant to long COVID, in my opinion, is there will have been a big peak of people who should have been testing positive in the community, but we were not doing community testing at that time. And I think that has a significant impact on many people struggling to get a diagnosis of long COVID because they weren't tested in the community. And we'll talk a bit more about that later on. Next slide, please. So it has felt like, and certainly this time, so May, June time last year, it felt there was a big black hole when we talked about long COVID. What was the prevalence? What was the frequency with which people were getting long COVID? What were the symptoms? What were the risk factors? How long would it last? What investigations should we do? What was the right sort of treatment? Next slide, please. Trish Greenhalgh, who is a professor of primary care, did a study specifically talking to healthcare workers, so people in whom you think they would be well able to navigate accessing care for any health system. And this was healthcare workers who were diagnosed with long COVID. And I think this will be very recognizable to many people experiencing long COVID, that it was, people described it as being miserable, strength sapping, no end in sight, that, as Jack described earlier on, finding difficulty being believed, difficult to access care with no clear care pathways and fragmented services. Next slide, please. So what's interesting as an infectious diseases physician is that this syndrome is not new to us. So Barbara Bannister is one of the sort of grandmas of infectious diseases in the UK, and she came up with this paper many years ago listing all the different types of post-infectious disease syndrome that she documented. So we were not surprised in many ways that there was a chronic sequelae, a chronic following on condition following a viral illness like this. We see it with many other viral illnesses, chickenpox in adults, for example, herpes encephalitis. We definitely see this. And some of what you'll hear is the learning that we've brought from experience with other syndromes, such as chronic fatigue syndrome, into long COVID. Next slide, please. So again, international data being shared. This is data from Wuhan, obviously the original site, following up people 3 months after COVID, and from Rome 6 weeks after COVID. So the Rome data shows you all the different symptoms that people had on the left when they were ill with COVID, and all the different symptoms on the right of people who are 6 weeks after having COVID. And you can see there's a real variety of symptoms: hair loss, fatigue, sweating, breathlessness, chest pain, anosmia is loss of smell, chest distress. So a big range of symptoms, up to 30% of people. And as you can see, what's particularly striking is the shape of these graphs are very similar. So very common for people to have fatigue, chest pain, breathlessness, joint pain, but many other symptoms as you go down the list. Next slide, please. This is UK data. So this is from the Zoe app. And again, this is showing that 1 in 10 people still having symptoms after 3 weeks after COVID. And the next slide. This is data from Sheffield. So we have been analysing people from the first wave, following them up with COVID. And again, what you see is how striking these graphs are all the same. So a real variety of symptoms. So some are particularly common. So fever, cough, breathlessness, and going out a number of days afterwards. Next slide. So I want to just concentrate a little bit on this, because this is about the knowns and the unknowns. So this is us following up patients again from the first wave, and we were asking specific questions of people. So the red bar, so we were asking about people's level of activity, people's levels of anxiety and depression, people's levels of mobility, pain and discomfort, and self-care. The red bar is people saying they had no problems.
green slight problems, purple extraction because they're on the left. You can see the data from 6 weeks after COVID, and you can see that actually the biggest bar by far is people who had no problems, which is really encouraging. But there were people with slight, severe, moderate, and even some extreme in all of those modalities. The EQ5 is a scoring system that you use for assessing people from this. What's really striking is if you compare the graph on the left with the graph on the right. So what you can see is, so for example, self-care, there are nobody at 3 months whose symptoms are so severe that they're unable to self-care. Do you see what I mean? You can see that the proportion of people who have improved is quite striking. It's moved on 6 weeks to 3 months. There's a significant improvement, and this is something that we're seeing with our patients. This is data. Yes, this is data from patients in Sheffield from the first wave. This is local data, but it's been replicated in quite a number of other things. We have the next slide, please. And this again is specifically, so first wave data, I think we had at that point about 200 patients, but we've got a lot more data that's been collected now with our second, what we consider to be a third wave. We consider the second wave that before Christmas when we were in second lockdown, and then we've very much had a third wave after Christmas. So same clutch of data, so first wave data, and we're looking at this again. So this is breathlessness after having had COVID. So red is 6 weeks and blue is 3 months. And again, what you can see is that it's that same scale of, so 1 is no problems at all, and 5 is so severe you can't leave the house. And actually at 3 months, there's nobody in the blue category in 5, and they have reduced. So we are seeing steady improvement. So that feeling literally this time last year, being when people were going to their GPs saying, I think I have long COVID, how long am I going to be ill for? How long am I going to take to recover? We can be more confident now that people do and have been making a steady recovery, and a large proportion of people will be better at 3 months, but not necessarily at 6 weeks.
Can you start to wind up, Anne? Sorry.
Yeah, I've got two or three more slides. Next slide, please. We've signed up. This is a national study called post hospitalisation, and we're continuing to recruit into that. Next slide, please. But that will draw together even more, and we'll be able to, and there's one paper's come out. I will skip this one due to time limitations. So if we can have the next slide, please. This is research again being done in Sheffield, looking at the effects long term of COVID on the lungs. Doing selected MRI scans, looking specifically about long-term damage to COVID in the lungs. Next slide, please. So, what treatments are available? First and foremost, we need to do proper investigation to pick out people who have got disease that needs intervention, such as heart problems, chronic lung problems. We know that some people get scarring on their lungs. However, there are a lot of symptoms that we are finding that the therapists are the most effective. So using pulmonary rehab for people who've got dysfunctional breathing, that's a sort of catch-all phrase for anybody who's struggling with breathlessness after a chronic illness. We know that the chronic fatigue team have a lot of experience in managing fatigue and pacing therapy. And there's a significant benefit from psychological support dealing with anxiety. Of course, above all, prevention is better than cure, and that's why we really want everybody to have the vaccine. Next slide, please. There's lots of websites out there. So there's the gov.uk supporting real recovery after COVID-19. Next slide, there is the self-help groups. And I think many people have found these online support groups extremely helpful in sharing experience and finding peer support. Next slide, please.
Are you nearly there, Anne?
Yep, last three. So there's the post-COVID rehab, which is going to be talked about very shortly. Next slide. You can just scroll through those. So these IAPT and the sorry, Alex. Yeah, thank you. So my summary is while there remain a number of unknowns, they are fewer than they were before. There are a lot more data to come with thousands of patients in. My message to everybody is good recovery from long COVID is possible. A lot of work has been done setting up the post-COVID rehab hub. And if people haven't been able to access care, then I would encourage you to go to your GP and request referral to the post-COVID rehab hub, because there's a lot of experienced people there to help you. And certainly there's a major role for the rehab and psychological services supporting people to get better from this illness. And that, I think, is my final slide. There's one more, I think, just to say thanks to my colleagues.
Thank you, Anne. Thank you very much.
I can see there are a number of comments coming through. Do you want me to deal with those at the end, Jack?
I wanted to bring Maggie in and then perhaps have a short time just to answer some specific questions.
Of course, yeah.
Just to remind, I forgot to say at the beginning that we're recording this session because it's very useful for us to review it, and there are people who've not been able to attend and we're requesting a copy.
Can I just, three of the queries are very similar, which is we weren't able to recruit everybody into the post-COVID study because at the initial start it was only based at the Hallamshire, and there was a delay in getting it set through. So if you were admitted to the Northern General Hospital, you may not have been offered an opportunity. We are doing our best to recruit everybody, to offer everybody the chance to be involved in all of these studies as much as possible. Thanks, Jack.
Thank you. We may not be able to answer everybody's questions, but if you put them in the chat, we will try to come back to them and answer them at some stage. Maggie, can I ask you to speak?
Yeah, that's great. Thank you. Is Alex able to put the slides up? Thank you, Alex. So my name is Maggie Quinn. I'm Operational Pathway Lead for the Hub. I'm a physiotherapist by background. I feel really privileged to be part of this work and really proud to be here today talking to you. In the audience is Sarah Jenkins, who's the Deputy Medical Director in Sheffield Teaching Hospitals, and also Charlotte Carolan, who is the Programme Manager for the piece of work that I'm going to present today for the Long COVID Hub. And obviously we'll take questions at the end, and I'll try and speak fast. Clear, because we're on catch up. So the next slide, please, Alex. So the next slide is just to reiterate very much that I hope that this presentation gives everyone who listens to it hope that we've got a rehabilitation programme in Sheffield to manage long COVID. We are on track and we are engaging with lots of people every day to get them on their journey for rehabilitation. So I hope at the end you feel hopeful about where we are in Sheffield. Next slide. So what we're going to cover, I'll try not talk about anything Anne's already covered with you, but what is long COVID, post-COVID? What post-COVID problems do people describe? And what services are available for people in Sheffield and the concerns that they have? So first, to just really define what is long COVID. So we interchange those two words, as Jack said at the beginning, and it's maybe not really important what they are called, but the fact that we open up conversations to talk about the whole of the symptoms and the syndrome. So the acute is that first phase of up to 4 weeks. Then the second definition we have is ongoing, 4 to 12 weeks. And the final definition, post-COVID syndrome, which is the whole purpose of the rehab hub for people that are more than 12 weeks. So those people where you and I both know them, we've all got friends and family who are still struggling with getting back to work, with managing their life, huge differences that they're still coping with at 12 weeks. Next slide, thanks, Alex. So 1 in 7 people will have the symptoms up to 4 weeks, 1 in 20 up to 8 weeks, and the focus of the post-COVID rehabilitation hub is that 1 in 45 will still have problems at 12 weeks. So if we go back to that second point that I wanted to make, which was what is post, oh no, sorry, you don't need to go back, Alex. You can stay where you are. But the second point that I made on my slide, which is what post-COVID problems do people describe? So we'll come with a list in our head of symptoms. We might start with fatigue, brain fog. But the very important thing we've learned on our journey is that we have engaged with patients throughout, and they have helped us design our service. We have listened to them actively to understand what have the problems been. So I'd just like you to read some of these patient quotes from phase 1. And as you're reading them, I will just let you know that the patient voice has been involved in the design of the service. It's been involved in the outcome measures we're deciding to use. It's been a part of the interview panel for the hub. So it's absolutely integral. It has informed the steering group, and Sarah Jenkins, as our director, has been informed by this patient voice as to where we need to go and what our journey should be. And you can see here that the problems people are describing, when we asked them what the problems were, they didn't really focus on fatigue, brain fog, but what they focused us on is I need someone to hold my hand. I need someone to help me navigate. I felt lost at the end of phase 1 when I was out there in the community. I didn't know who to turn to. And one man that I spoke to, in his patient story, he said, I was discharged, I was out in the community, I didn't know who was going to review me. So I knew I needed an X-ray, so I put on my mask and I just rocked up. And that was his words. I just rocked up in radiology and asked for an X-ray, and he got one. So I can't emphasise enough just how much the patient voice has shaped where we are in Sheffield today and continues to do so. Next slide. So the design of the service, we learned from phase 1, as I said, that people with long COVID, was a service for people discharged from hospital, and that's always been there and it remains there. So we have a vast array of community services that are out there. But for people that are at home struggling in the community, there wasn't an access in to get support and to get help. So that pathway has now been designed, it's here. And the access into that pathway is that patients would present to the GP. Now, I've been in lots of conversations with people in council groups and voluntary services talking about this, and I've had some real pushback. Why do we need to go to the GP? Why can't we just pick up the phone and come to you? And the reason for that is that long COVID symptoms may be caused by something different to long COVID. We need to really know that we're treating long COVID. We would, the worst scenario that we can all conjure up in our heads, as I described that, is that somebody has got severe fatigue, losing weight, and that there's something more sinister, maybe a cancer causing that, and there's been a presumption that it was COVID. So very much the GP is our team leader, if I'm going to use that word, and they are a part of the hub. So referrals come through the GP, and all of the tests that need to rule out anything sinister are all done. They have a nice bundle of tests, and they then will refer that person through to the hub. The patients can also come from discharge from hospital. So if patients have been in hospital, they'll all be given a leaflet about how to access services. So they'll have a patient information leaflet on how to come through to the hub at the appropriate time. So once they've maybe got over that acute infection and need to access the hub for longer term support. Next slide, thanks. So this slide is very much representing the whole of the pathway. So the hub is one part of the pathway. The hub is made up of therapists and a rehab medicine physician that supports, and the hub coordinates the journey of the patient across acute critical care as needed. So that might be an ANS team for an infectious disease review, it might be into respiratory care for a respiratory opinion, it might be into community services for problems with mobility with an older patient. So the hub coordinates across all these services so that the patient is enabled to make the most of those services that are visited. So very much they described in phase 1 that they needed a hand holding, but as a physiotherapist, as a therapist, I very much want to enable a patient to feel in control of their own journey. So walking alongside them rather than necessarily holding a hand and empowering them to find their way. Next slide. So these are the symptoms that you all have heard a lot about. What I'd just like to describe is just a few of the patients that we've had through, or even just a couple, with time allowing, just to talk about the implications of those symptoms. So the people that we're seeing are a much younger cohort than I expected. So it's people of my age, it's people in their early 50s, late 30s, and it's people that are coming to us with problems of brain fog, preventing them get back to work, fatigue, not allowing them to kind of do a whole day at work, not even managing to get through the occupational health assessment to get back into work, chest pain of no known origin that's being tested but still persistent chest pain that's creating anxiety and depression and no confidence to exercise. So there's some of the kind of implications that those symptoms have on people's lives that we're seeing. Next slide, please. So how the overall design, so if we think it's a slide down pyramid, at the bottom there, the orange, big orange bracket is the offer of the hub, and that's the offer of your COVID recovery and guidance to do a self, a journey with the handheld, a guided journey using prescribed exercise, using prescribed fatigue programs. The next level, the blue level, is where people may access more specialist care in the community, such as active programs, pulmonary rehab services, to give specific exercise programs. And the top light yellow is the people that we might need to go back into acute care for some specialist advice. And we would go through that loop into acute care via the rehab medicine lead, that's Ram, and he's part of the hub. Next slide, please.
Can you wind up, Maggie, soon?
I winded up fast now, yeah. Okay. So this is a diagram I love. This is the end one. So we've got the patient in the middle there, and the little orange circle around them is the hub. Then we've got arrows coming in and out into voluntary sectors. So we're working with Waqas, occupational health services, other voluntary services, into IAPS, psychological services in Sheffield health and social care, into our own community services in STH, and then you can see as well back into acute care. So lots and lots of services that we are linking with a hub at the core. So we're very much a hub and spoke model, the hub coordinating the referrals out to all these other services and making sure the patient gets the right support that they need to meet their needs. And I think I'm there. Next slide. So this slide, just you can't really see the age categories at the bottom there, but the 42 is in the age category 54 to 60, and the 37 number that you can see there is the younger age category 38 to 44, I think it is. So you can just see that patients coming through are a lot younger. And I wanted to end on this slide because I wanted also just to let you know the patients are younger, but we're not getting huge numbers of patients from more deprived areas, and we're not getting huge numbers of patients from BAME backgrounds. So really the patient voice, I'll go back to that real steer that we're getting from the voice. We're now looking at how do we get out, how do we get to this seldom heard group, and how do we engage and make our service available to all. And thank you very much.
Thank you, Maggie. You were breaking up a bit, but thank you.
Sure, sorry.
That's all right.
I think we're all
Thank you.
breaking up a little bit.
Yeah, thank you. I'm just really conscious of time, so I really want people to keep their questions for the breakout room. So I'm going to move on to Waqas, please. And it sort of feels as though looking at some of those seldom heard communities is very appropriate. So Waqas.
Thank you, Jack. Hi. Hello, everyone. I'm Waqas Hameed from Donald Wellbeing, Senior Health and Wellbeing Worker and a Link Worker also. So I'm here to talk about the virtual clinic for long COVID in underserved communities. This is a research project which has started last month, and it's a joint project between Sheffield Hallam University, Advanced Wellbeing Research Center, and Donald Wellbeing as a partnership. Dr. Sally Fowler is here today with us in this meeting, and I am part of this project as a recruiter. So we're looking at recruiting 12 participants to work with them around long COVID. I'm not going into long COVID as we just heard about what is long COVID and how people feel. So I'll just talk about my role in here. The study is to recruit people, to identify people, and then talk to them and recruit them for if they're happy to be in the search. There are some inclusions and exclusions. I would say exclusion in a way that we don't want to, but just because it's a short piece of work and we have to go through quickly. So inclusions are that anybody over 18 who lives in, so specific area chosen is Darnell, Tinsley and Handsworth, which is S9 and S13 postcode. Anybody who lives here over 18 and they're not under active observation for long COVID or under NHS rehab, then they can be in this study. Self-reported symptoms and being able to use being able to use the tech because it's a virtual clinic. If they don't have technology, we can support them to provide the technology, but they need to be able to use it, and actually the language, if they can go through themselves speak English or they have a family member who could support them. So that's inclusion. And one of the exclusion is that they are over 6 weeks into long COVID. Before that is we can't have them. So identification of people. So my role is to identify through the community links, which I have and Donald Wellbeing. So I've been out and asking people if they know someone, and so they could talk to me. So I could talk to them or they could talk to me. I started with few people who came through during the work last few months. And I went back to them and said that you asked me this question. There is now research going on. Would you be like to part of it? And they said yes, and they're already in research. As I said, we needed 12 people. We are about 8. We have about 8 people consented for this, and more than 5 people are already doing their sessions now. The process of the research is that identifying and then sending information out to people so that they can agree to be part of it. Once they agree, the information sheet is sent to them so they can read and then formally send me the agreement that yes, I can pass their details to research team. And once I receive that, I pass the information to research team and they get in touch, and a more formal consent, a link is being sent to them which they can give the consent, which is module. And after giving consent, they've been sent another questionnaire to fill in before they can start the virtual process of their assessment. There are 3 sessions, virtual sessions they go through, and for doing each session, a thank you £10 voucher is being would be given to them as well as to say thank you. But again, as the people who have been through study at the moment, who have done few sessions, I've spoken to them after, and they're really happy to be there just to share their experience and to talk about what happened to them, because they said some of them said this was the first time we could actually sit down and say what happened, because our GPs, we've been going to them, but they didn't have much time to ask us, actually tell us what happened, what change happened in your life. So this is end of the study. Once a person is going through these 3 sessions, there will be actually the support will be that if they are agreeing and they're happy, then there can be a letter to their GP to discuss next step. On the other hand, my role in this from the beginning is recruiter, but then I provide the extra support as a link worker, as a health and well-being worker, which working in the community. That's the social support before, during, and after. As I said, if somebody start going into study, but they need extra support then and there, they ask me that their benefits, they can't go to work, they need to have benefit sorted. So I would help them then and there during study or after what comes out to study. And as we just looked at long COVID rehab, I would support people once they finish. If they need to knock on the door of GP and say, I need to go to long, I would be supporting them to get to the point where they need to be.
Waqas, can you say something about about David?
Yeah,
He was going to come, but
so yes. So David, I've spoken to David, and so David, who also called Dave, was a very active member of our men's lunch club. That's how I know him. Until COVID came, we were doing regular, and he was attending regularly lunch club where we were doing a half an hour of aerobics exercise. That's how I know David. But when I rang the other day to check about men's starting back when the restrictions are lifted and we want to start the same program again, during the talk he said, I don't know if I would be able to do the same as used to do because I'm struggling. And then that was the time I said, why you are struggling? And he said that I think I had COVID. But when I had it, I couldn't get the test. And after a few weeks, I just didn't bother about the test. But now, since then, I'm struggling. He said, what he said is I had chest pain and breathlessness, but it's gone worse. Now I struggle even to do a little bit. So going back to the same, I would like to come back, and actually I would like to know if I can go back on track how I was. So that was one of the thing in the week when I was going and doing my exercise and enjoying that time. So that's how he came into, and then I asked him if he would like to be part of research. What he said is actually we can look at it. So yeah, he became, and he already had 1 session, and he said that he was happy that he could explain to people what's happening. Thank you.
Brilliant. Thank you very much, Waqas. Really good work, and the research again. We'll find out more. Sorry to hurry people. I know I feel as though I'm hurrying people, but I'm just conscious of time, and I do want to get to the breakout rooms. Tom, I'm going to move on to you. Tom Heller there?
Just unmute myself.
Sorry.
Okay. Yeah, thanks, Jack and Waqas and Anne and Maggie. The last speaker always has a sort of a job to get something in that hasn't been said already, but I give it a go, really. So I'm a guy who's, I had COVID in the very early days, early days, and I was one of the people who didn't get tested in any way. And actually, I'm only convinced that I have had COVID because my wife was more severely ill than I was at the time, and was in hospital and was tested positive. So I don't have any doubt whatsoever that what I had was COVID, really. I'm usually in really good nick and all that sort of stuff, but I do have a couple of comorbidities, so things going on as well as so I do have long-standing diabetes and a bit of high blood pressure and things like that. So these are the things that we're told makes the COVID a bit worse or more likely to get COVID. And I think that's true with me really as well. So immediately after the infection, I was pretty much sort of zonked out, and I tried to do various things and join in with different activities and things, and brain fog was certainly a feature at that time, and I could sort of like sustain very limited amounts of activity and very limited amounts of sort of concentration really, and I sort of feared that there was a big sort of cognitive decline, but as well as that, a couple of big things were happening as well. I got a really severe aggressive arthritis, and it turned into one of these autoimmune diseases that is sort of that has required quite a lot of treatment and immunosuppressants and things like that, which was triggered by the COVID. And this is now, so the COVID doesn't just produce sort of non-specific things. I think it does produce very specific things as well, and actual organ damage and all that sort of stuff. My diabetes, which has been well controlled for a long time, it's completely out of control. And again, I think there's now evidence that diabetes, people even without diabetes to start with, the COVID can affect the pancreas, and either inflammatory disease of the pancreas itself, or actually knock out the cells that produce insulin. And I think that that goes on with more people than, I suppose the point of me being here at all really is to say that lumping everybody together as long COVID isn't really helpful, because I think there are other things that really do need attention. And so you all want to know how I am now. I'm much better. So I've taken, I'm still more tired than I want to be, but I'm sort of managing that. I'm learning the difference between sort of tiredness, lethargy, exhaustion, and fatigue. So it's sort of like, it's a complicated business really, wanting to do more than I'm able to do at the moment really. Diabetic control isn't good. And I think that's because there's, what remaining cells I had at, in the pancreas producing insulin are really under stretch at the moment. So joints are much better because I'm on these immunosuppressants and steroids and things like that. The foggy brain is debatable really. I think it's part of the confusion really, and I don't know if it's just, I can't do the things that I used to do, but then you're going to say, well, you're mid-70s, get on with it, So the other big point I want to make is about, I've called this next thing about hard to reach groups, and I think doctors have become a hard to reach group. It's really difficult. I'm actually seeing my GP tomorrow, but it's taken weeks of waiting to see him. And I know there's COVID and it's difficult, and they're all in car parks giving injections and things. But really, it's really hard now to reach a GP. I love the GPs. It's not a criticism of them. It's just how stretched the service is and how underfunded it's been for so long and under-resourced. So the other thing that happens is the sort of off-putting messages that you get. So don't approach us, So if you ring, suddenly when I was ill, right at the beginning, and my wife was pretty desperately ill, I rang the NHS, via the primary care service, and you get this long message saying, don't bother us, which I think is probably, well, I was, I'm not a shy wallflower, but I was put off. I gave up and didn't try the primary care, and you get exactly the same message from 111. So we were left sort of without without help. And some of that continues now. So I haven't tried ringing 111, but when you ring the GP, you get this long spiel before you get through to anybody. And it's really off-putting. And I think this, you know, this sort of thing, as a, you know, I've crossed the barrier from being, you know, a member of a primary care team to being a punter, you know, a patient, a person needing a bit of help. And it's easy to be put off. So you get this sort of impression that everybody's so overworked that you're sort of not quite worth it. And you know, I've said this, that doctors are hard to contact, and so they are. But it's also easy to be put off, really. And so I think that's one of the other messages that I'd like to say. So things like routine care that I used to get for diabetes is more sort of tapered off into, you know, as I say, I'm seeing the doctor tomorrow, but I haven't seen, I think I've only seen, you know, it's been a year now. And it's my first time to actually see someone face to face. And I think the same perhaps goes with investigations. They're more difficult to get hold of. At the same time, all these things are going on, I'm really keen not to be defined or labeled as someone with long COVID or anything else, really. I want the things that can be sorted out to be sorted out. So that includes the things that might be labeled as long COVID, but aren't really. There are other things going on, other processes going on. And I really do need those, you know, and I think we all need those sorting out before being told it's sort of long COVID. What do I think is going on? Well, I know, you know, obviously I'm going to be doing a bit of the sort of background, and I think some people do have a sort of continuing infection, and you know, some sort of it may not be so much in COVID, but other sort of infections can linger on in the body. I'm wondering about the whole immunological thing that goes on with in the second week of infection with long COVID, these cytokine storms and things like that, and whether that was what, for me, triggered this autoimmune disease. And I wonder if there are other people who are being now labeled as long COVID have got one of these other processes as well, really. Also, things that make you tired. I'm on quite a lot of medication at the moment, and so maybe some of it's side effects of medication, but again, without having access to, you know, doctors to chat it through, I'm left to reading those great long things that come in each packet of tablets and thinking, well, is some of the tiredness that I've got to do with that, really? So what I'd like to say is really about if you're worried whether you've got long COVID or not, make sure that you do get to see, you know, people that you trust and all that sort of stuff, and make sure that they're checking for actual organ damage and not just labeling you as long COVID. So that's about it, really. Just like finally, really, about the media attention that long COVID's getting. And obviously it's really good that that people are now recognizing that post-viral illness is a thing, and that it can cause a range of different issues. But there's a lot that isn't helpful, really. So I think that long COVID isn't a thing. I think if there are a million sufferers, I think it's a million different things. I think everybody has got something that's slightly different and needs the individual attention. So I would just like to share my screen, just if I can do that. Can people see the screen, my screen?
Yep.
So this is just a bit of light relief after the stuff I've been talking about, really. So the media attention and simplistic imagery, I think can add to the problem. So every time you listen to the news or watch, you know, or watch a newspaper or something, or online or whatever, you will get sort of imagery about long COVID. So I've just collected a few of these that I've found particularly unhelpful. So there's this thing, this one, and I don't know if you can see, there's some sort of worm coming out of the ground here. I don't know what this is, but you're being held back by this this sort of COVID thing. And similarly, another sort of one with the same. Now, one of the problems is COVID's such a beautiful virus, isn't it? This is I think it's an actual electron microscope slide. It's absolutely beautiful. And that's a problem. They can't resist showing you pictures like this. And then there's this sort of thing, which is like everything you can possibly think of is or could be long COVID. So there's COVID sort of in the background, and there's all these things that might be, and I don't quite know what this is, why this is. It's a beautiful image, but it doesn't help me as someone wanting to understand a bit more about what's going on for me. Similarly, this one, which is so full of stuff that you couldn't possibly have, you'd be tired just reading that. This is the other sort of image, is it all in our minds? Well, I think that we can dismiss that one really. But this is the sort of thing that is appearing in the newspapers on a regular basis. And this sort of thing, it's like, it's all a trap and it's all too much. And similarly, things like this. So, and this one just bizarre really. Why this is necessary to turn into a graphic. And this is one of my favorites really, which is it's now called long haulers. We're long haulers. We've had COVID for a long time. We're long haulers. So this is such a literary, a literary picture really. And this is my least favorite of all, but I just thought I'd share it as a joke. So that's all I've got to say. I don't know if it was 10 minutes or less, but did my best to say things quickly.
You've all done really well, because I think this is a complicated topic to properly discuss. I would like to, probably people have got lots of questions, but I think because there are still almost 40 of us, I think it's better if we break out into the rooms. I think it'll give people an opportunity to ask questions, have a bit of discussion. It's 5:05 at the moment. I'd like perhaps 20 minutes and then we'll come back for the last 5 minutes. I'm not expecting any reports back, just some final comments really. So join your rooms, please. Any final, so I'm not going to ask people to report back or anything, but any final comments anybody wants to make? I shall try and look out for anybody with their hand up. Yes, we're recording it, so once it's available, Alex can send it out to anybody that wants to view it again, and there will be other people who've already expressed a wish to see it. Great. Okay, there are people who are up for that. I can't see any hands, so maybe
Masood has got his hand up.
Oh, sorry.
Sorry, I want to just say something as a frontline clinician. I'm a GP, UCC. I see many patients come with the chest pain, young people, and when you touch them, they have a acute trapezius and pectoralis muscle spasm, and ECG is normal. Some of them is being successful to encourage the ANE to do troponin. Troponin is negative. I believe we need to have some definition of that, then spread that one, educate the public that this is not the heart problem or heart attack. This is the muscle spasm around the chest and providing this one, because they are long queue sometime in the A&E. That's wasting time of the people, taking the patient to the risky place like a hospital, A&E, urgent care center, and giving frustration to the colleague as well, that they say that we repeatedly see that one, that sometimes we miss other patients. I believe we need to have definition as an expert people to find out what's happening, because when I discuss with a colleague, they say that, oh, just we don't know what is happening, it could be something else. But this is in my 5 or 6 hour shift, I see at least 6 patients like this coming with a chest pain, pleuritic chest pain or not pleuritic chest pain. When you touch them, trapezius is very tender, pectoralis tender, but pectoralis is not all the time. And when you do ECG completely normal, and you cannot do troponin on everybody. And we didn't miss very much patients just I want to send some feedback that please, when you are doing a hard job, that we are very thankful of you, push the people to nice guideline or anybody to have a look at the site and give us some guideline perhaps. Second is that give to the public education. When we talk to the people, say that there's nothing wrong, we need support from the back. Thank you very much. I don't want to waste your time more than this.
Thank you, Masood. Sarah, you're muted.
I think I'd been practicing or something. As the programme lead for the city response to long COVID, I'm really, really grateful for the opportunity to hear people's experience. It's so important that we hear what people are going through in terms of symptoms and their experience of the service. So finding ways to listen better is something we're looking at, and we'd like to continue listening to what people need and what service they think would be helpful to them is number one. We are doing some education work with the CCG for GPs, so that last comment we'll pick up. And just to say thank you. I know how hard this is, and I know how hard it is to spend time, and I agree, Jack, an hour and a half is a long time, so I'm really, really grateful that people have taken time to share their experiences.
Thank you, Sarah. As I said, I don't really want to continue much longer. But if this has been useful, I mean, if you perhaps do the survey that Alex has sent out, then we could repeat it again, and I think we could, we can build on it really, because I think, and certainly the experiences that people were saying in my little group are really, really important, and I think it's really important for the profession, if you like, to listen to patients and believe them and have them on board in terms of developing the service that we need. So thank you very much to everybody, to all our speakers, Anne, Maggie, Waqas and Tom, and for all of you being with us for a long time really, but I do want to finish. So thank you very much and goodbye for now. Another session in 2 weeks, which will be back on vaccination, some interesting local research that we've been doing around inequalities and vaccinations and where people are and aren't being vaccinated in the city. So that's in 2 weeks' time. But thank you very much. Great to see you all.